Welcome to AETCM, the Emergency Medicine Channel. Sure.
Yes.
Today I'll be presenting a case of an 83-year-old male, a known case of COPD, who presented to our ER with complaints of acute onset of breathlessness 1 hour back. On initial 10-second assessment, patient was conscious, oriented and obeying commands, but was not able to complete full sentences. On a primary survey, airway was patent, no pooling of secretions, no gurgling sounds. Coming to breathing, there was decreased chest movement on the left side. On percussion, left side of chest, there was a hyperresonant note, and on auscultation, there was a decreased air entry on the left side of chest. No added sounds. Saturation was around 89% in room air, and respiratory rate of 36 per minute. We are suspecting an unstable left pneumothorax. Coming to circulation, BP was 170 and pulse rate of 106 per minute. At this point of time, 18 gauge IV cannula was inserted and patient was connected to cardiac monitor. We arranged for a point of care ultrasound, and in point of care ultrasound showed absent lung sliding in left side of the chest and with a barcode sign in M mode. And right lung sliding was normal, and we arranged for a ICD, and chest X-ray was also ordered. After the chest X-ray came, it was confirmed that there was a left side pneumothorax, and at the level of the hilum, the interpleural distance was around 2.1 centimeter. So ICD tube was inserted in the fifth intercostal space in the anterior to the mid-axillary line, and it was kept in underwater seal. Coming to disability, the GCS was around E4, V5, M6, and pupils are equal and reacting to light, moving all four limbs. Exposure temperature was 99 degree Fahrenheit and GRBS of 110. Sample history, adjuncts of primary survey.
Before going to that, you tell me what are the reasons for acute breathlessness in emergency room?
Acute breathlessness, we have pneumothorax, pulmonary embolism, and
what is commonest cause? Have you come across pneumothorax in last 1 month? How many cases you have come across? How many cases of pulmonary embolism you come across? Tell me the common causes.
Acute exacerbation of bronchial asthma or COPD.
Okay.
Then
pulmonary edema is the most common condition. Pulmonary edema and asthma, COPD. These are the two important things you see every day. Then whatever you told, acute pulmonary embolism and pneumothorax. Children? Foreign body. Yes. So these are the 5 major causes for acute breathlessness in emergency room. Okay.
Adjuncts of primary survey. ECG was taken, showed sinus tachycardia. ABG showed pH of 7.362, PCOT of 37.8.
What are the ECG changes in acute breathlessness? Tell me various conditions. What are the changes you expect? Why you are taking ECG in this case? Why you took an ECG in this case? You know that it is a pneumothorax.
Yes.
Why did you take an ECG?
There was a tachycardia of 100.
You are seeing on the monitor.
Yeah, I can see. Then to rule out, we can see, check for pattern for pulmonary embolism. We can check for S1, Q3, T3 pattern in ECG.
You can see or you may see?
You may see.
Okay. S1, Q3, T3 in pulmonary embolism. Okay, then other.
Then MAT, multifocal atrial tachycardia, can be seen in acute exacerbation.
Okay. Carbon dioxide, elevated carbon dioxide levels, you can get MAT. Okay. In pneumothorax, will you get any change?
No.
Yes or no? Which side pneumothorax it is?
Left side.
Left side. Can you get any change in ECG? Voltage decrease is the most important thing. Sometimes the axis also can change. Heart is completely pushed to one side, then you may get an altered axis. Okay. So whenever you ask for an investigation, you should know why you are asking. Unnecessarily, we should not take an investigation. If you are taking an investigation, there may be a reason for that. Okay.
ABG to check for a PCO2 retention or PO2 decrease, hypoxemia. pH
what is the ABG value in this?
This is 7.362 with PCO2 of 37.8 and PO2 of 62.6. Mild hypoxemia was there.
Okay.
Then CBC CRP point of care was also taken. Total count was 7,000 with CRP of 24.2. Mild inflammatory parameter was there.
Okay.
And coming to sample history, 83-year-old male, known case of COPD. 83-year-old male, known case of COPD, benign prostate hypertrophy, came with complaints of acute onset of breathlessness 1 hour back. It progressively increased. Initially, he had baseline of MMRC2. It progressed to MMRC4, and there are no other features of any orthopnea or PND. There is no history of any cough, fever, chest pain, or any palpitations. He is not allergic to any medications. He was on montelukast and inhalers, tiotropium, salmeterol, and fluticasone. His past history is all COPD and BP, benign prostate hypertrophy.
A smoker, chronic smoker.
Chronic smoker. On examination, he is conscience oriented. There was clubbing was present, and no pallor, icterus, signal.
Clubbing is a feature of COPD. It is not a feature of COPD. So where will you get clubbing is not a feature of COPD, but you can get clubbing in COPD. Where will you get? One is malignancy. Rapidly onset clubbing may indicate malignancy. Repeated infections. COPD patient, if he is getting repeatedly infection, then there is a chance of clubbing. Otherwise, clubbing is not a feature.
Then coming to respiratory system examination. On inspection, there was decreased chest movements on the left side. The trachea was appeared to be deviated to the right side. On palpation, the tracheal deviation was confirmed to be mildly deviated to right side, and chest expansion was reduced in the left hemithorax. There are no inspection. There was no dilated veins. Then coming to there is vocal fremitus was decreased on the left side.
When you are looking for dilated veins, which condition you get dilated?
Dilated veins you can see in tension pneumothorax. If there is massive pneumothorax, it can be dilated veins.
It is not a feature. It can occur, but it is not a typical feature of any tension pneumothorax. Where will you get dilated veins on the chest?
Lung tumor.
Also not a good
SVC
answer.
obstruction, apex of lung tumor.
SVC obstruction is a classical
Pancreas
condition
tumor.
where the patient have breathlessness, you have extensive increased blood vessels all over the upper chest. What is the typical feature of this SVC obstruction? So some heavy manual laborers also will have a lot of veins on the chest and hand. How do you differentiate that? Elderly individual also can have a lot of veins. How will you differentiate that?
Flushing also above.
Flushing is a feature of SVC obstruction. Then what else?
JVP elevation.
JVP elevation is seen in cardiac failure also. Here, what is the difference?
Flow.
So all cases come here. Last week also one case was there, SVC obstruction, full of veins here, upper limb, everywhere. What is a typical feature of that?
Direction.
There is no direction. Even if you lift the hand, there is no flow. It is a typical feature. Pemberton sign. What is that Pemberton sign?
Raising the
Not raising
hand, there will be flushing.
Normally, when you lift the hand, whatever vein is there in the upper limb, it will drain very, very fast. There is a obstruction here, it will not drain. Okay. So, patient will have engorged veins all over the chest. Even if you lift the hand, it will not drain. That is a typical picture. Last week also one patient was here on the right side. He was on ventilator. He had typical obstruction on the right side. Okay. Tension pneumothorax, you may get, but it is not a very classical feature. Even what you told is cardiac tamponade also, theoretically you can get, but clinically we don't see. Okay.
Coming to percussion, there was hyperresonant note on all zones, and also on auscultation there was decreased air entry in left side. There was vocal resonance was also reduced. There was no added sounds. Normal vesicular breath sounds were there.
What is the normal response of ER doctor when you are suspecting pneumothorax?
You have to check
Will
for
you able to percuss? Will you able to take an X-ray? Will you able to auscultate, vocal resonance, vocal parameters? All these things are possible. That are given in
secondary
books. That are given in books. Theoretically, it is correct. What is the normal response? What has to be a normal response? What has to be a normal response? If this pneumothorax patient is having pneumothorax, hypoxemia is there.
Stable or
Stable patient immediately.
Do needle decompression.
Needle decompression.
Yeah.
That is a typical treatment you have to give. Okay. Here the patient is stable. That's why you could able to do all these things. Okay.
Rest of the systemic examinations are normal.
Which system you want to examine here? What all systems you want to examine here?
CVS, cardiovascular system.
Any hypotension? Why hypotension?
If there is hypertension, there will be tension pneumothorax.
Okay. What are the clinical findings of tension pneumothorax?
Tension pneumothorax,
Clinical finding.
hypertension.
What is Beck's triad? You may be knowing that.
Muffled,
that is not
Beck's triad.
fully this one. This is related to that.
Raised JVP, muffled heart sounds, hypertension.
Where will you get?
In cardiac tamponade.
Okay. So here also almost similar finding you get, but exactly it is not. It is not Beck's triad. So here also you get reduced heart sounds. Since it is left side, reduced heart sounds, you can have elevated JVP and hypotension, bradycardia. All these things are the same features you can get, but Beck's triad is typically designed for that. The term is given for cardiac tamponade. Okay. Investigation. What investigation you did?
Initially, to confirm the pneumothorax, you have to take chest X-ray.
What is a normal response? Chest X-ray, it is not preferred investigation in pneumothorax. If available, you can do it. But we have ultrasound machine. No, everywhere it is there nowadays. How do you diagnose? You have already told.
Yeah, ultrasound. You have to check for lung sliding. If there is absent lung sliding, it is more in favor of, and we can confirm it with M mode.
Okay.
To check for a barcode or a seashore site.
Okay.
That we can differentiate.
Okay. Have you done in this?
Yes, in this patient we did.
Okay. Okay. Then X-ray was taken.
Yeah, then X-ray was taken. Then according to the centimeter, depending on the interpleural distance, we can also guide our management.
Okay.
If it is more than 2 centimeter, we have to insert ICD tube. If it is 1 to 2 centimeter, we can initially try, if it's possible to try for the needle decompression initially and watch for response.
Okay.
If it is reducing less than 1 centimeter, then we can manage conservatively as well.
What is this conservative management?
We will check for symptom progression. If there is any worsening of breathlessness or
oxygen in this patient?
In this patient, depending on the oxygen sensitivity of the patient, this is a COPD patient, so we'll have to keep saturation from 88 to 92.
Is it
target?
Is it required to give oxygen in all COPD patients? All pneumothorax patients. Huh? If you give oxygen, what will happen to pneumothorax, which is not tension, which is not producing any clinical finding? If you have a patient with minimal pneumothorax, why doctors start oxygen for that patient? You should read. That you should know why we are starting oxygen. Okay, something to do with nitrogen. You have to read it. Okay, so it can be given even if the patient is having normal oxygen saturation in blood. We can give oxygen. It can slowly reduce the size of pneumothorax. But here the patient is having some clinical findings, so we have to relieve it fast. That's why we are giving, we are putting ICD on this patient. Okay. What happened to this patient after ICD?
After ICD insertion, you are admitted under pulmonary medicine.
So you have to read about oxygen therapy in a stable pneumothorax.
And they had taken HRCT chest.
Why HRCT is taken?
They wanted to rule out other secondary causes of pneumonia.
Can occur.
It can be if there is any underlying bronchiectasis or any bulla.
Bullei.
Bulla.
Bullei will be there. Yeah. All COPD patients can have upper low bullets are very, very common. Bullei will be there. Okay. Is there any bullei?
No, in this patient, only there is emphysema changes in the apical region.
Okay. In chest X-ray, how do you differentiate pneumothorax and emphysema? So this patient, if you see the X-ray, both sides it is black in color. How do you differentiate?
There will be bronchoscopal markings you have to trace.
Okay. Markings are minimally seen in normal lung, even with emphysema, but it is not at all seen in pneumothorax. So that it is very difficult sometimes clinically, but even then you can make out. Okay. Then what are the things we should avoid in emergency room in pneumothorax? Avoid.
We should not keep the patient on NIV.
Okay, that is very important.
Because
The one thing we should remember. Okay. Mechanical ventilation, anything to be avoided?
Before mechanical ventilation, we have to relieve this.
Okay, we have to put an ICD. That is very important. Then PEEP?
PEEP has we kept a minimum PEEP.
Okay. What else you have done for this patient? What all things you have done for this patient after that?
After this, we monitor the patient.
So what happened to the tube? You were discussing about the tube placement and underwater seal.
Yeah.
What happened to the tube? How do you stop it? How do you remove the tube after some time?
We'll check for the repeat X-rays, and if there is no or minimal pneumo, then we can plan for remove and also according to patient's
I'm asking how to remove it. Plan for removal means what?
We'll have to clamp
the
tube.
You have to clamp and see whether the patient is deteriorating or not. That is very important. So that when you go to ICU, you will understand. You cannot remove it suddenly. Okay, then what other treatment were given to this patient other than your ICD placement?
For that patient had a mild infection as well, so antibiotic was also.
What is the evidence of infection in this patient?
There was a CRP rise of 25 and also polymorph predominance was there. And in HRCT chest also there was infective etiology consolidations was seen.
Okay. So what do you do? What antibiotic you have started?
They have started on ceftriaxone.
Is ceftriaxone is a good antibiotic for in this condition? Yes or no? Yes or no? Is ceftriaxone is a good antibiotic for COPD with acute exacerbation?
No, ceftriaxone cover only gram-negative.
It is not a good antibiotic. It is an average antibiotic which covers gram-negative organism, especially in lung. You need to cover both gram-positive and gram-negative. So, what is the ideal antibiotic you give?
Piperacillin.
Okay, that is costly antibiotic. Normally, you start from normal antibiotic, then you go for any level. Normally, what drug can cover both?
Amoxicillin, clavulanate.
What is an antibiotic? You have to tell me the standard guidelines. No, don't tell what we are practicing. You may practice. I may give amoxicillin. You may give augmentin. She may give piperacillin as well. And that is not guideline. PG should tell me the guideline. That's all. Fluoroquinolones. Respiratory fluoroquinolones are the drug of choice, like moxifloxacin, levofloxacin. They are the drugs of choices. Okay, you can select piperacillin as a vector. That's a higher antibiotic that covers both gram-positive, gram-negative. That is correct. But ideally, you have to start a moxifloxacin or levofloxacin as a first line, and you can go ahead with any other antibiotic. Okay, what else you are given in this patient? So antibiotic is one choice.
Nebulizations.
Nebulization.
Short-acting bronchodilators and steroid nebulizations can be given.
Okay, then.
And the injection, steroid injections can also.
Steroid injections are given then. What else? So you have treated this patient and you will be admitting in ICU. I want to know what is the ICU treatment for this patient. So you have put an ICD, you have started on oxygen, you have started on antibiotic, you have started on nebulizations. Then
Magnesium sulfate.
Magnesium sulfate can be given. Okay, then. You have to tell a full treatment package. Don't tell me one or two things. You have to treat this patient and you have to discharge the patient. So far you are treated, but this patient will come to your ICU. Now you have to tell me the treatment. What else?
It's just physiotherapy.
Will you give chest physiotherapy for this patient in acute phase?
No.
This is one condition we may not advise chest physiotherapy in acute condition. Later you can start. If the pneumothorax settles, then you can start. This condition you may not advise physiotherapy. Then what else? What else you are doing in your ICU? Tell me that.
DVT prophylaxis if needed.
Huh? DVT prophylaxis is required. If the patient is admitted in your ICU more than 48 hours, definitely you have to give DVT prophylaxis. Then
The incentive spirometry.
incentive spirometry should be trained to the patient. Okay, that is very important. Then you have to tell me fluid, you have to tell me diet, you have to tell me the vaccination. Everything has to. Oxygen, how much oxygen you have to give. All things are important, no? How much oxygen should be continued for this patient?
For this patient, you have to keep a target O2 saturation of 88 to 92.
Okay,
So that you have
enough.
to titrate.
Okay, then how long you continue oxygen? How do you discharge the patient? How long you continue? Long-term oxygen therapy should be advised. Then
Protein diet.
protein diet, high protein, high potassium diet. Then vaccination, pneumococcal and H influenza vaccine. Okay, that is a complete treatment. Okay, so this patient, even if you treat with your simple ICD, patient may not improve because he has got a basic problem. Okay, and age is a factor. Okay, is there depending on his age, should we do something for this patient? Can we use normal doses of drug in a patient like this? Can you use or not? Geriatrics, if you go to geriatrics, their dosages will be like pediatrics. When the patient become older, you have to reduce some of the drugs. Okay, you have to go according to creatinine clearance. Okay, there also creatinine clearance is very important. So some drugs we have to titrate the dose. Okay, here we have not started anything like that. But if you go for piperacillin, tazobactam, meropenem and all, this much higher doses may not be required. So there you have to titrate the dose again. Okay, that is also very important. What else?
Before discharge, what should you advise the patient? Other than all this discharge advices, one more advice. Because this patient had a probable bulla rupture, right, and pneumothorax. So, anything regarding travel and all?
Air travel should be avoided.
For the next 3 months, air travel should be avoided, and this patient is very unlikely to go for diving and all. Diving also should be prevented. In case of young individuals and all, that advice also should be given.
And what are the other causes of pneumothorax other than this is a bulla rupture, and you know that this is normal.
Mainly spontaneous and acquired. We divide it into spontaneous and acquired.
Where will you get spontaneous pneumothorax?
Spontaneous, there can be primary or secondary causes.
What type of patients you get spontaneous pneumothorax?
Primary spontaneous will be seen in subpleural bleb rupture or any bullous rupture.
Which type of patients?
Marfan's
Very tall thin
patients.
individuals are more prone for spontaneous pneumothorax. They are more prone, but others also can have. Otherwise, other than
secondary causes can like COPD, TB, malignancies, ILD.
Okay.
Patients can have. Then acquired causes, we have the traumatic causes, blunt trauma, penetrating trauma. Then iatrogenic causes can also be that due to biopsies or central venous cannulation.
Okay. Whenever you put a central line, you take an X-ray to rule out pneumothorax. And one reason is to where is the placement of the like your line, that is important. But all central line placement, you have to take an X-ray and document that there is no pneumothorax. Okay. Anything else? Anything else you want to add? Okay. Thank you.
Thank you.